And in no particular order, because they all come in quite quickly, get ASIM to be involved or responsible for credentialing. MPs are a political workforce, proposal for nurse professional development, not a solution to service delivery. Maybe a good one to respond, Matt or Wayne.
Get ASIM. Sorry, so the question is what get ASIM to be involved in or responsible for credentialing of MPs. Yeah. So is that a question or a comment?
I think that's a comment. I think I want to hear you respond to the MPs are a political workforce proposal, not a solution to service delivery.
Okay.
Well, you've just been speaking.
Yes.
Wayne, have a drink and respond.
Oh dear. No, they're not political, but they've been politicised. I think they've been polarised in some extent. I think if the end game is to improve patient-related outcomes, they're definitely in that workforce. They're definitely within that scope. There are issues, boundaries, challenges. There's lots of counter pressures. There's gaps. I think in a fit-for-purpose sort of concept to achieve best patient outcomes, they are definitely in there. They're not a political thing, just as being a nurse or having nurses working in EDs is not a political thing. But they have been heavily politicised, which I think is probably impacting on the quality and the dexterity of emergency healthcare delivery. That's my view. But yeah, it was.
Mirror that.
It's not a question we haven't heard before.
Yeah.
If this new toy's broken, I'll be very upset.
Matt, what's your thoughts with the question about the scope of practice? Because I know that's highly variable across sites. I put my hand up, former UK MP, but not an MP here, but it's quite variable. Is that a weakness, a strength? Is that a possibility?
It's a weakness for sure, and as I sort of alluded to, I think that having a broad scope of practice is actually probably helpful, but how we make that consistently applied is where the real challenge is, I think. I think if I'm true to the evidence actually supports that the NP has been by far and large tested and trialled and evaluated in fast-track models, and so that's where understandably where the predominant focus of the role should be, because that's what the evidence tells us where they work as effectively as our colleagues and with good outcomes as for patients. I think if we were to expand the role into other areas of the ED, that should be evaluated and measured against things that are important to patients. Can they sign?
What do you think about that one?
Oh my God, yeah. So the work, yes, they can sign a medical certificate, but you can't sign the work cover forms. We need to have work cover legislation changed, and that's actually happened in South Australia and I think in Queensland, where they've actually managed to change the Work Cover Act to enable NPs to be able to sign these forms. And a lot of it still is around whether you have access to a provider number. And so that's still for NPs working in public health institutions, not entitled to use a provider number. So that's still a challenge for NPs at the moment. Scope of the NP will always compared to MOs. If the MO doesn't want them in the department or town, they won't be there. Yeah, sure. Or it might even not be just the medical officers. It might be the executive of the department. It may not be within the nursing remit of that department as well. So I think also the other thing is very, very much so that the role is still tied up with the personality or the individual that actually is doing it. And it's really important. If you've got pardon my French, but if you've got an idiot doing the role, of course it's not going to be well embraced, or if predecessors have not been the best champions for the role, then of course people are going to think negatively about the person or the position. So that's still at play, and of course there's always professional boundaries where, you know, primary care overlap or with emergency medicine overlap. I see the role actually as very complementary to emergency medicine colleagues, and that, you know, that Venn diagram where you overlap the two, I think it beautifully complements the spectrum of emergency medicine. So I think those who have worked with those NPs that cover that enormously see the benefit of how this helps the department, and it can free the workload so that critical care focus can be where the emergency physician plays, and then the emergency nurse practitioner can practice within the lower acuity patients. But it doesn't mean that with either role that you don't have to know how to manage each end of that spectrum. It's just where you predominantly play. So that's where I sort of see on my position on that.
You don't have to answer everything that goes up.
Oh, yeah, good.
This is just, we're embracing the putting stuff up there and seeing what other people are asking.
Yep.
It says there, who is the governance over NP duties in a busy ED, and the cherry picking is not always beneficial. Oh.
Yes.
What's
So the governance of the NP role, so within New South Wales health facilities, and in fact within all Australian facilities, that you have to have a multidisciplinary committee endorse a scope of practice, and the scope of practice of that individual very clearly stipulates how and the nature and the capacity that that individual works, and their referral privileges, all of that sort of stuff sits within a scope of practice document, and that document should be made available to whoever needs it. Usually that's the role of the ED director and the nurse manager to disseminate that and have good conversations with staff members and induction and orientation about how an NP works within their department, so that there isn't any of this argy-bargy stuff that happens on the floor in the moment. That's not the right time to be sort of, I think, addressing those issues. Did you want me to talk more?
We'll move on to some questions on the floor. Wonderful Slido engagement. Thank you very much.
Thanks.
Congratulate yourself. So we could go back to the traditional way with the more vocal and less dexterous people like to ask some questions that perhaps didn't come up on Slido. And there'll be some roving mics around.
Hi, Matt.
Hi, Sarah.
Thank you. Lovely presentation. I just wanted to say, so you mentioned the review that New South Wales Health did a few years, is that about 5 years ago?
Yeah.
I think it was about 5 years ago. And
Thompson and
I remember
Mason.
the results of that study were, that review in New South Wales was overwhelmingly that there was support from all parts of emergency to address the issue of variation in scope of practice, but then we didn't do anything with that. So
Yep.
where do you think that's headed? You mentioned that there is support now for scope of variation to be addressed. Can you just explain
I think
a little bit where it's
for
headed?
me, part of that is, as I mentioned, is I think that there is a need for having a nationally recognised training platform. So some would call it a fellowship program. I see that happening in the States. Others have. There is Australian literature out there. I reviewed an article for AENJ recently talking about a program that they've instituted at Redcliffs in Queensland. The problem again with that is that some things are included on that that might not be included in other facilities. So we really need to cater for the spectrum of emergency presentations, and each individual or department then needs to choose that actually, well, these skills are more pertinent in our department. It still doesn't mean that you don't need to know about them. It's just your practice might not be today or within this department actually utilising those components as much. So I think we need to develop still a national fellowship program, or want of a better word, a credential per se, that allows us to be consistent. And then how that is utilised is then up to each department. But, you know, that's how I sort of see that, Sarah. And then I think in terms of having training networks would be a really useful way to help break down some of that. So we need cross-pollinisation and allow NPs to not just train at one facility, that they do. I like the emergency medicine model where they rotated through different facilities to gain different experiences. And I think that would in part help address part of that, I think.
Any more questions from the floor? There was quite a few.
I had a question for Wayne, actually, and that was around the triage thing. Often we see, Wayne, triaging and the paediatric issue, no child should ever get a Category 5. Like, does that often, did that resonate or come out in any of the...
Yeah, so it came out in two ways, TCAS and the survey. TCAS is built to flip its variables when it sees a child, so you'll have the paediatric markers sit there, and the paediatric network have ratified those. We had one, and it's probably more of a bespoke thing to really talk about. It's a child that had multiple tick bites. There were several instances where a child with multiple tick bites, even Category 3s. So when we drilled down on these, it was more that people emotionally, intuitively thought this was actually quite severe. So there does seem to be local cultural guidelines, rules sort of thing happening at the local end, at the coalface. There's definitely divergence from what the triage scale is meant to be about, but we did see a large group, specifically children, all getting minimum levels. So I think the smallest we gave, was like 2% ever got a 4 and a 5. Everyone was sort of driven towards that 3, 2, 1 area. Is it the right tool? Is it the right decision? That's future work. That's about, how do we make a tool more relevant? Or is it that they're seeing something that's not being documented? Yeah.
I guess in that was there in general, when you got the auditors, was there a general consensus that over triaging in paediatrics happens, and did that happen against the auditor's opinion around it? So did the auditors tend to give more Category 3s, 4s and 5s for conditions like, ankle injury, but they happen to have pain, so there's...
It didn't happen so much with the auditors, but when you look at the differences in their allocations, you can see that more should have been pulled down towards the 4s and 5s as opposed to where they were being maintained. But no, when we looked at the classic pain, tox, injury, wound, no, they were all behaving appropriately, because TCAS gives you the category, well, not category, gives you the descriptor, and you have the text in there as well. But what we did see is the auditors were pulling them down a little bit more to a lower category. Yeah, so I think it's more cultural practice. Oh, hello, Sarah.
Thanks.
Sorry to be a microphone hog, but I just have a question for you, Wayne. When in my travels around and speaking to people, one of the issues that always comes up when you speak to nurses about triage is the pressure from particularly RCA teams and, people getting beaten around the head for various practices at triage, even though, if it was emergency staff reviewing the RCA, and according to our statewide policy, which is fairly, supportive of standardised triage practice, that despite all of those things and evidence and all of that sort of thing, people are still getting beaten about the head when it comes to particularly RCAs. It would be great if this particular, and I think this is a fantastic piece of work that you've done and can see lots of applications for it around the state, that the results of the surveys locally are used to help inform RCA teams and get them to really understand. Because what I find is, the focus becomes so much on, oh my God, they gave the wrong triage category. Don't worry that no one else in the whole department followed, the particular guideline or policy around that patient's particular condition. So it would be great if this was used to take away some of that negativity around always focusing on it's the triage nurse's fault because they gave the wrong triage category.
Yeah, I think it will gradually impact upon that. I think the key thing is that objectivity. When you're part of an RCA, you get the whole thing, so you're immediately biased, and you get who triaged them, the triage category, so you're almost baited towards pointing fingers. But I think we do lose the true message of an RCA. The emergency is a system of care. Hello.
Yeah, hi.
Hello.
Hi. Trish Whelan, Director of Critical Care for Murrumbidgee and Southern. Yes, look, I think I'm in the unfortunate position of having to do a lot of clinical reviews in RCAs, and you have to apply the standard of care on the day, and it's just so important that you get a peer who's familiar with the circumstances under which that nurse works. A lot of these nurses in rural, they have to be experts at aged care, experts at mental health, experts at triaging. They're not doing triage 24/7 like they are in teaching hospitals. And just on one of the points you made, we do concentrate a lot because we realise it's a big hole in our system on updating our nursing staff in E-Tech across Murrumbidgee and Southern on a regular basis because we realise it's an issue, but that number, that label that the nurse hangs on the patient, particularly when there is no doctor present in the department, it is quite a determiner of that patient's fate too. So, but I just wanted to talk about standard of care.
Yeah, I think you're quite right. I mean, TCAS it's not built for the nuance. I mean, we've all got contexts and pressures in areas that need to be uniquely understood, and they should be explored at that RCA with compassion. But TCAS is there more as an educational aid and more as a monitoring, auditing aid, but it's also there to help identify areas for improvement. I'm completely with you that, when understanding how that decision was made, you also need to understand the context in which it was made in. The thing I can share with you, though, is that most over-triaging occurs after 4 p.m. And that might be around, a peak period in EDs. But I completely agree with you that triage decision-making should be reviewed in the context in which it occurred.
Roberto Forero from the University of New South Wales.
Hello.
Wayne, I did a review for the college a few years ago, and one of the main findings were that the complexity dimension should be incorporated as a secondary triage option or something like that, but that hasn't been developed. What do you think about that? And secondly, in terms of the dynamic process of triaging, shouldn't be more like a dynamic category, having the opportunity to change according to the progress during the progress of the assessment, etc.?
Yeah, I'll take the last question first because that's the one I can remember. Yes, there is absolutely the ability to be dynamic with the triage process in terms, obviously, if the situation gets worse, you up triage. However, we see that very rarely occurring. What you tend to see, and probably quite rightly, is the patient is taken to the immediate resource point, and we will manage that patient. We're not going to sit there and modify the triage and then take them towards resus. We're just going to take them there. In terms of complexity, there is complexity recognised in paediatric variables and mental health variables, but not in general adult triage variables in terms of, are they a representer? Are they someone who's previously engaged? Are they someone who is at... there's a little bit of risk in there as well, but not... And it's very difficult to appreciate complexity. Although what you might find is that patient A comes in, there's someone who's going to need 3 or 4 nurses at any one time to move them or to care for them, and nurses will put that patient in an area that's best suited, nurse-patient ratio-wise. But yes, it is difficult to appreciate complexity in the general areas of triage, but there is recognition in mental health triage and in paediatric triage.